Hello, everyone, and welcome to a breastfeeding class presented by the Breastfeeding Clinic in the Helderberg Basin, Cape Town, South Africa. Just a quick disclaimer. The information that is provided in this program is to assist you in exploring all available options to empower you to make well-informed decisions, to help you feel in control, be responsible for, and have confidence in your choices. Information should please not be substituted for the diagnosis and treatment of any medical condition, and also please never disregard professional medical advice or delay in seeking it because of something that you have received in this program. And this recording is also not intended to replace professional or medical or other kinds of advice. So today we are going to talk about anatomy and physiology. So when we have a basic knowledge and understanding of how breastfeeding works and where milk is made and how it gets from the mother's breast to the baby, we will be able to better understand and appreciate how to manage and prevent potential and real breastfeeding difficulties. So during the next 4 recordings, we will look at what the breast looks like, the anatomy, and how it works, the physiology. So in this recording, 1 of 4, we will start looking at anatomy, focusing on the appearance of breasts and nipples. So looking at the slide, which breast and nipple do you think is best for breastfeeding? So we have different shaped ears and noses and hands and nails and even breasts and nipples. And breast comes in different shapes and sizes. So breast size differs from one woman to the next due to the amount of fat in the breast, not the amount of milk producing tissue. And babies can breastfeed from almost any shape. So just a quick note on breast shapes, and we will be looking at warning signs of insufficient milk making tissue in a later recording. But some signs of insufficient milk making tissue as a warning sign for milk production issues include an intramammary space of more than 3.8 centimeters. That intramammary space is that flatness from one side of the breast to the other. Another sign might be marked asymmetry. So most women have one that's a little larger than the other, but this is like marked difference in shape or size. And then unusual shape could also be a warning signs, and there are some others that we will discuss when we look at coping with insufficient milk making tissue in a later recording. Okay, so about nipples. Again, we all look different. The nipple and areolas are flexible and it's shaped to fit a baby's mouth and the baby's palate and tongue and gums during a feed. And nipples can vary in size and shape and elasticity and how far they stick out, etc. Now, these variations are only relevant if they interfere with the latch and the suckling. So a nipple's appearance at rest is not as important as how it functions when it is in the baby's mouth. Let's look at different types of nipples. So the common nipple, the first one on top, that's also called a normal nipple or a protracting nipple or an everted nipple. It sticks out at rest and it sticks out even more when it is touched or stimulated. So the majority of parents have common nipples. So it sticks out when it's at rest, it becomes erect when it's stimulated or cold, and a baby usually has no trouble finding or grasping this common nipple, and then the baby pulls a large amount of soft breast tissue into the mouth, and then they stretch the nipple and part of the breast tissue to the roof of their mouth. Now, a flat nipple may be soft and pliable and become erect when stimulated, or it may have a short shank or neck or stem, and it may remain unchanged when stimulated, which makes it a little more difficult for the baby to find and grasp. And this nipple might benefit from the use of a syringe or other devices to gently increase its protactility. And then an inverted nipple. Inverted nipple could either be truly inverted or only inverted appearing. So an inverted appearing nipple may become erect after compression or stimulation or when it's cold, and they usually present no grasping problems for the baby. However, some inverted appearing nipples retract on stimulation, making it difficult for the baby to attach. So these might also respond well to techniques that increase nipple protrusion, like for the nipple that remains flat with stimulation. Now, truly inverted nipples, though they are very uncommon, is more difficult for the baby to grasp because they retract when stimulated due to adhesions that bind the nipple inward. Or it might be due to short ducts inside the nipple itself. And you can do what you want. You're not going to be able to stretch this nipple. So truly inverted nipples, as I said, they retract when they are at rest or when they are stimulated. And a baby should be able to latch onto this if a parent forms the breast for the baby to latch on. And it's also easier for the baby to learn to do this before the breast is really full. So before the milk supply increases around day 3 or so. So if you wonder, how can I tell if my nipples are flat or inverted? Because just by looking at a nipple that appears flat, you won't be able to really tell. So to try and determine whether the nipples are flat or inverted, you can do the pinch test. So gently compress, the areola, the dark area around the nipple, about 3 centimeters behind the nipple. And when you compress that area, if the nipple does not become erect, it's considered to be flat. If the nipple retracts or becomes concave, it's considered to be inverted. But I think I've mentioned it, but the true inverted nipple won't become erect when it's stimulated or cold. So you might know that you have a truly inverted nipple before you do the pinch test. So if a nipple becomes erect, a nipple that appears flat at rest, and then you do the pinch test and the nipple becomes erect when you do the pinch test, or even when you stimulate the nipple or roll out the nipple or expose the nipple to cold, that nipple is not truly inverted, and that doesn't really need any special treatment. But if you are worried about your breasts or nipples appearance with regard to breastfeeding, just chat to an IBCLC before baby arrives. Now, before you worry your baby won't be able to feed from a flat or an inverted appearing nipple, babies breastfeed. They don't nipple feed. So the nipple forms only about a third of the teat the baby suckles from, and the other 2/3 are breast tissue. The problems come when we have a baby that has a disorganized suck due to being born premature, or maybe due to the effect of labor medications, or maybe a very long labor, or maybe the baby was separated from their mother and now they are a little bit disorganized, or maybe the baby has some tongue tie issues or tethered oral tissues. Now, these babies often need a harder stimulus along the palate to be able to either start sucking or to keep suckling. And they often only need this for a very short period of time. But talking about a harder stimulus, we will be discussing nipple shields in a separate recording because nipple shields comes with a lot of terms and conditions that we need to discuss. Okay, thank you so much for watching this recording. In the next recording, 2 of 4, we will be continuing looking at breast anatomy in more detail. So please visit breastfeedingsa.co.za if you would like to book a private consultation and receive the class notes. And you can also navigate the class recordings easier from the website. And please feel free to subscribe to this channel for more breastfeeding class recordings. And take care till next time.